Good afternoon, everybody. We are right at the top of the hour, so I think we're going to go ahead and get things started for today. First of all, good afternoon, and thank you for joining us for Fix Your Face, How an Affirming Sexual History Can Improve Sexual Health Engagement and Outcomes, hosted by Healthcare Education and Training with presenter Dr. David Malebranche. My name is Brandon Heinbaugh, and I am the HIV/STD Project Manager, at HCET, and I will be moderating the webinar today. Let me briefly introduce you to Healthcare Education and Training. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. For more information to keep up to date with HCET events, please be sure to follow HCET on these various social media platforms and visit our website. Now I will quickly review some housekeeping information. If you would like to receive nursing contact hours for this webinar, please complete the form that was sent with the login information and fax that to the number listed at the top of your screen, or email it back to kbradford@hcet.org. A link to complete an event evaluation will be sent to you via email following this webinar. Your feedback is greatly appreciated. As always, archived presentations and a list of upcoming events can be viewed on our website. And at any time during the presentation, if you have technical difficulties, please contact Jen Stevenson at the email listed on your screen. In order to receive nursing contact hours for this event, participants must attend the entire webinar, complete the event evaluation, and submit the nursing contact hour form to HCET. The presenter disclosed actual potential or perceived conflicts of interest in the following categories. Throughout the presentation, we encourage you to send your questions via the chat box. To submit a question, hover over the main screen, then select the blue chat icon. Once selected, the chat box should appear on the right side of your screen. To send a question at any time during the presentation, please send it to all panelists. This ensures everyone behind the scenes can view your question. We will hold all questions until the Q&A portion at the end of this presentation. Now I would like to introduce you to your presenter for today. David J. Malebranche is a board-certified internal medicine physician and public health official with expertise in men's health, student health, racial inequities in medicine, and LGBT health, as well as prevention and treatment of HIV and sexually transmitted infections. He is currently an associate professor of medicine at Morehouse School of Medicine. Dr. Malebranche is an experienced qualitative HIV behavioral prevention researcher who has completed several studies on sexual health among Black men of diverse sexualities. Dr. Malebranche has published over 50 articles in medical and public health journals such as the Annals of Internal Medicine, the American Journal of Public Health, and The Lancet. He is known as a dynamic speaker worldwide and has appeared in documentaries on CNN, ABC News Primetime, TV One, and Black Entertainment Television, BET, for his experience on HIV in the Black community. Dr. Malebranche served as a member of the President's Advisory Council on HIV/AIDS from 2006 to 2008 and was the HIV clinical expert on WebMD from 2010 to 2012. He also appears in the video series #AskTheHIVDoc, which promotes HIV education on prevention and treatment, and Revolutionary Health, a YouTube health series that is a part of the Counter Narrative Project, an advocacy organization for Black same-gender loving men. In 2015, Dr. Malebranche published his first book, a memoir about his father entitled Standing on His Shoulders. He currently resides in Atlanta, Georgia. Without any further ado, I will be turning things over to Dr. Malebranche. Thank you.
Hey, thank you, Brandon. And I want to thank Healthcare Education and Training for inviting me to do this presentation today. And I apologize, Brandon, the only correction I would give you on that biography that makes me sound much better than I am is that I recently left my position at Morehouse School of Medicine. So I'm taking a little bit of a break in between jobs, and working on some other stuff, and also trying to practice what I preach, which is self-care. So I'm just honored to be here today, and I'm looking forward to giving this talk. All right, so for the agenda today, I'm going to focus a little bit on the epidemiology, also talks about sexual health in medical settings. We'll spend some time discussing or exploring healthcare bias, and then talking a little bit about sexual history taking in language, because I think we talk a lot about what questions you're supposed to ask, but I think there are some dynamics happening before, during, and after all this that I think we should get real about as well. And then leave some time for summation and discussion. Brandon and I were very intentional with this to make sure that we didn't overburden with a lot of slides, to leave some time for conversation and discussion about some of the solutions that will move forward with this. Okay, so we'll start with, we're talking about sexual health in general. It's not just HIV, but these are the recent stats from 2018, the state of STIs in the United States. And so as you can see, according to the CDC, the STIs have surged for the 5th straight year and basically reaching an all-time high. So you see with cases of chlamydia, 19% increase since 2014, gonorrhea, 63% increase, syphilis, 71% increase, and then an 185% increase in syphilis among newborns, which, really maybe speaks to some of the laxity that we may be having with making sure people are tested, especially mothers who are pregnant and coming in. But you can see when we talk about sexual health and the burden of STIs in this community, things are getting worse rather than getting better. And when we talk about young people, and my particular heart is doing student health in adolescents and young adults, even though I was trained as an internal medicine doctor, young people account for a substantial proportion of new STIs. And again, this is data from the CDC from 2018. You can see with cases of gonorrhea, the ages of 15 to 24, which would loosely be considered adolescent and young adult, represent about 70% of the gonorrhea cases, 63% of chlamydia cases, almost half of the HPV cases, and then so on and so forth, going down a little bit when it comes to genital herpes, HIV, and syphilis cases. So again, I think particularly when it comes to things like gonorrhea, chlamydia, HPV, and herpes, we need to keep our focus not only on everyone as far as age is concerned, but particularly on our adolescents and young adults. And just in general, when we talk about sexual health, which is the focus of this presentation today, we're talking about a whole bunch of things. So it includes reproductive health, includes HIV, includes physical health, it includes the environment, it includes knowledge and education, teen pregnancy, prevention, student wellness. So all these things kind of constitute student health. So when we're talking about this stuff, it's not just specific for HIV, it's overall kind of approaching sexual health in a general foundation. So this is a definition from the World Health Organization. I don't know whether it was created in 2006, whether this definition was put out in 2006, or whether this was before that and just kind of re-emphasized in 2006, but I'm just going to read this verbatim. Sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sex experiences free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. And I love this definition for sexual health because it really focuses on some of the things we don't talk about, is that it's not just the absence of disease. We actually use the word pleasure when we're talking about sex, which is something we forget. And then also the sexual rights. Phrases like respect, protect, and fulfill are things we all should be doing as members of the medical community and within medical settings. There's some abundant literature with sexual health in clinical settings, and I'm just going over a basic smattering of some concepts here. But these are 4 concepts that I think stand out for me from some recent studies that have been done. Patients prefer active inquiry about sexual health concerns. So there have been some studies talking about how patients want us to ask them about their sexual health and not wait for them to bring it up, because obviously it's a vulnerable and scary position to talk to, and people have experienced judgment from clinicians before, so they'd rather us bring it up. And sometimes people will leave a clinical setting with a sexual health concern because we haven't brought it up. And they don't mind not being addressed at that point because we haven't brought it up at all. I also noticed that age matters with some of these studies, both for providers and patients. And what I mean by this is that elder patients or patients who are older, and we're talking about 50, 60 and above, may not actually bring up some of their sexual health concerns. It could be for fear of not being heard. It could be because other things are more of a priority, but that's a concern. And then also when it comes to providers, we don't ask our elder patients as much about their sexual health concerns. And that's also a combination of things. One that we could be talking about. There are other concerns like high blood pressure, diabetes, heart failure. And then there's also the bias that we have, is that when people get older, they stop having sex, which is a completely erroneous and unfounded bias, but we still see it happening a lot in medical settings today. The third point on this slide talks about perceived receptivity. And we're talking about how perceived receptivity to sexual health inquiry influences providers' history-taking practices with men. When I was reviewing some of the literature, what was interesting is that a lot of the great sexual health literature that I could see is actually not in the United States. Maybe that's not surprising to many of you who are watching this right now, but it's actually international. And so what we mean by perceived receptivity, it means that providers are actually judging people and seeing whether someone, we're prejudging whether we think they're going to receive sexual history taking questionnaire well, or whether they'll be offended, or whether they'll respond in a positive manner, particularly with men. So we have to acknowledge that we have a bias. We size up a patient when we get them in the clinical setting and say, well, are they going to be offended? What's going to happen? And that drives if we engage in the sexual history at all sometimes. And then finally, there are some recent studies that talk about targeted medical school curricula that shows promising results. And I've, in my 20 years of working in this field, have been blessed to be invited to some medical schools in particular to talk about this. And typically what I've seen, what seems to be effective, is when medical students are given some of this information about the broad nature of sexual health and sexual history taking early on in their training, be it first year or second year. The problem with that is it's very institutional dependent, and it depends on the curricula itself, because a lot of administrators and instructors and course directors strongly feel that there's not enough time to talk about this. They call it biopsychosocial stuff when they're trying to get all the hard sciences into the medical students early. So I think it behooves us to realize that, you know, sexual health history taking is a complement to all the hard science, and we need to teach this earlier. And there are some studies that show it is effective, and the students appreciate it as far as fostering good practices early on in their medical careers. So let's explore healthcare bias a little bit. So the one measure that I've seen predominantly in medical settings and in public health literature is the implicit association test. And when it comes to examining bias among healthcare staff and healthcare workers, providers, they have found there's a number of studies that find that there's positive attitudes towards whites among healthcare providers and healthcare staff, negative attitudes towards Black and Latinx folk. And then it's not more or less than the general population, it's actually pretty similar. So the notion that once those of us that are navigating in general society, once we put on our white coat, or once we step into our workspaces in medical settings, that suddenly the bias that we carry out in general society kind of washes away from our being is completely false. And we carry that with us when we interact with our patients, our clients, as we'll call them. So there are some studies that talk about, specifically with HIV, there was an interesting study where they examined conversations between patients and medical providers called the ECHO study, and published some years ago. And they did some racial comparisons between how providers who were predominantly not Black and predominantly white, and the patients who were predominantly Black, how the providers actually responded to them and what their language suggested in compared to their white counterparts. And what they found was that there was more verbal dominance, more directive language, and more dialogue about adherence with Black patients than white patients were concerned. And then I think it's important to note that with the implicit association test and some of these studies that we see, a lot of them do look on a smaller scale level. And so the influence, a lot of people are in denial about this, that this kind of healthcare bias exists, and they're saying, well, where are the outcomes? And so you will see some studies that say, well, this bias we know does exist, but does it actually influence outcomes at the end of the day? So that's what we want to see. Where does it influence viral suppression among people living with HIV? Does it influence HIV testing practices among patients? I think that's where the rubber meets the road. And so we have to be rigorous in moving forward with our research and make sure that we're doing more studies along those lines, or else, to be quite frank, a lot of people actually don't believe this plays a role unless you have a p-value or a confidence interval attached to it. Okay, next slide. And just talking about how this happens globally. HIV stigma, we know from a lot of literature, does exist in medical clinics from China, Latin America, and the Caribbean. There are studies that show the fear of discrimination among men who have sex with men deters their accessing healthcare in Nigeria and Swaziland. So regardless of their HIV status, people are afraid to go into healthcare settings because they think they're going to get discriminated against. On the converse side, there was an interesting study in Kenya which showed that challenges with confidence among providers with regards to MSM sexual health issues and counseling prevented them from having these conversations. So the providers were being very honest and saying, look, we don't know what we're talking about, or we're not really confident talking about, you know, diversity in sexual orientation or sexual behavior if it's non-heterosexual, and saying that they actually needed some help with stuff. And in the United States, there's discrimination against people living with HIV that happens in healthcare settings. There have studies that have been done with medical students and virtual patients or role-playing with patients that found that young Black MSM experience more PrEP and HIV stigma among providers. And then, like I said before, provider-patient communication appears to play a role in all this. And so we need to really focus our attention on that. One of the studies that I thought was interesting that recently came out last year was about barriers and facilitators for antiretroviral therapy adherence among HIV-positive Black and Latino MSM. And these authors did semi-structured interviews with 84 participants in Atlanta, Baltimore, DC, LA, and Chicago. And only 27.4% reported consistently taking antiretroviral therapy. And as there were a bunch of themes that came up around this whole thing, one of the things that was interesting that they found was that a lot of it had to do with the dynamics between the provider and the patients themselves. And so the authors, one of their conclusions at the end of the study, which struck me, was men were more likely to take ART when having providers who communicated effectively and were perceived to treat them with respect. And although this study is with participants who were living with HIV, I think it's important to note that communicating effectively and perceptions of whether you're being treated with respect or not happen long before an HIV diagnosis. So we have to incorporate and listen when our patients are telling us this, that these are the things that are important with adherence. And when we have something like 27.4% consistently taking ART, there's a lot of work that needs to be done. Okay, so let's talk about sexual history taking in language for a little bit. So before the sexual history even happens in a clinical setting, we're talking about sexual orientation and gender identity. And for a lot of this, this is common knowledge. You guys already know this. And the acronym that we use is called SOGI, so sexual orientation, gender identity. It's kind of an umbrella acronym that covers terms like lesbian, gay, bisexual, transgender, cisgender, just to show kind of the continuum of sexual orientation and gender identity. This is a figure that I like to use a lot, and I love this figure, and they've actually expanded on, this was the initial genderbread person, but they've expanded it to genderbread person 2.0, 3.0. I don't even know how far it goes right now, but this is the one that I actually like the most. And if you look at that barcode on the bottom, that scan code, you can actually put it, I did this with my screen earlier as I was preparing for this talk. You can actually pull up the website that talks about the conceptions of this, but they go into detail about the 4 different angles of kind of sexual identity, sexual orientation, gender identity, gender expression, and biological sex. And gender identity is defined as how you in your head think about yourself. And it's the chemistry that composes you, like hormones, and how you interpret what that means. And this can go in a continuum from you identify more as a woman or more as a man, or if you're somewhere in the middle, or if you don't want to be binary with it, you can say gender queer, gender nonconforming, or gender non-binary. And again, that's how you see yourself in your head as far as your gender identity is concerned. And again, that's a continuum. Gender expression is kind of how you demonstrate your gender based on your appearance. So it could be your looks, and it's based on traditional gender roles, whether you tend to act or dress or interact more on a masculine continuum or feminine continuum, or in the middle where you're a little bit androgynous, and a lot of people tend to embrace both masculine and traditionally feminine qualities. Biological sex is more about kind of the objective measurable things like hormones, chromosomes, external organs. And so you can either be on this continuum where you present as far as biological sex more on the male spectrum or more on the female spectrum, or in the middle would be intersex. And we think of conditions like testicular feminization syndrome that would be considered part of that continuum in the middle. And then finally, sexual orientation is the continuum about your attraction, like your sexual orientation, who you're physically, spiritually, and emotionally attracted to. And it could be the same gender, it could be opposite gender, or it could be both genders, or anything kind of in between. So when we're thinking about sexual orientation and gender identity, it's important to note that all of these levels come into play. And the mistakes that I've seen most commonly is that people mix up gender identity, whether you're cisgender, transgender, gender nonconforming, with sexual orientation, with who you're attracted to. And I see people actually interchanging these, and they're very drastically different. And so we have to be careful when we're doing that. So again, what we see a lot of times is that with a lot of our patients, and just in society in general, people will be choosing pronouns and say what pronouns are theirs. And so some people will say what your preferred pronoun, but I even see a backlash against that, because preferred means to think or seems to intimate that it's some kind of choice that you're having. So people will tell you, my pronouns are she, her, he, him, they, them, if they don't identify on the continuum or on the binary, I'm sorry. And so these are kind of some examples of the pronouns that people use. And if you expand that out a little bit further, you would think with our general conversation, it does tend to be more geared towards binary gender definitions or binary gender language. So instead of we say, hey, you guys, how you doing? Try using folks, or talking about, instead of guys, saying folks, because even though you may not realize it or someone may not say it, you are actually ostracizing them or making them feel isolated or apart, or offending them or triggering them by using this kind of specific gender language. And then instead of saying things like ladies and gentlemen, say distinguished guests, or say folks, something more general. And then instead of his or her, use a pronoun like theirs. Someone left their phone at the table, someone left their thing here. What are they doing? These things are simple fixes. And once you get into the habit of doing it, you'll realize that some people will really, really appreciate that you're not excluding them by using those specific binary terms. And I know for a lot of providers, this is difficult because we're asked to do a lot of things in general. And so changing language is part of a cultural thing. So don't look at it as like a diet, like a short-term thing. Look at it as something that you constantly try to integrate in your day-to-day practice, and it'll become easier the more you do it, kind of like wearing a mask during COVID-19. Okay, so I'm gonna take a little time with this slide. This is from a podcast called Core Internal Medicine, or Core IM, which I found to be very effective for a whole slew of different general internal medicine practices and topics. But this one was about pearls for trans affirming care, and it was a wonderful podcast. I'm gonna start at the top here. So they were saying, instead of letting your discomfort get in the way of asking about pronouns, start with your own pronouns, then ask your patients. So for a lot of people, they'll say, for example, hi, I'm Dr. Malebranche. I use the pronouns his, him, or he. What are your pronouns? And then let the patient kind of tell you. For a lot of people who aren't used to this, they'll say, you know, what are they talking about? But once you get used to it, and once you experience more people who are either on the continuum or non-binary, they really appreciate that you start off with that introduction, or just use general terms that don't specify he or she or one kind of end of the spectrum either way. And then in your electronic medical records, instead of documenting your trans patients as male to female, which we call M to F or F to M, use the acronyms AFAB or AMAB, which stand for assigned female at birth or assigned male at birth. And then again, this is just about cultural sensitivity and humility. And instead of using the billing code cycle for gender dysphoria, which kind of speaks to or hints that, it's some kind of delusional condition here. Use other billing codes such as hormone imbalance or hypogonadism, which speak to maybe there's something going on with the chromosomes or hormones that we may not understand, but we're acknowledging that it's a real thing rather than just saying, oh, somebody's a little bit off by thinking this way, which gender dysphoria kind of hints at, if not states it altogether directly. And then instead of dwelling on your mistakes that you make with a patient, especially with the trans patients, acknowledge the error, apologize, and move on with the encounter. And I'll tell a story about this. I used to work at UPenn Student Health Center in Philly, and I had a trans male patient that would see me. And he and I were fine, and we basically worked to get his hormones on board, and everything was cool with that. And he had a partner who was assigned female at birth, but identified as gender nonconforming. So they used the pronoun they or them. And I remember a couple times with him in patients or in our clinical visits, he would talk about his partner, and I would say, well, how is she doing? Because I had met them before and I had seen them in the waiting room. And again, what they presented to me was kind of a feminine external appearance or performance. And so I said, how is she doing? And he looked at me and he said, it's they. And I said, okay, my bad, I apologize. And we kept it moving. And then later on in the visit, I said it again and I said, she. And he rolled his eyes at me and was like, it's they. And you could tell that he was getting exhausted with me. And I apologized again. I said, look, I'm pretty new. This was back in 2013, 2014. I said, I'm a little bit new to the gender neutral pronouns. I said, so please forgive me. I said, but I will not make that mistake again. And then we moved forward. And sure enough, I made sure I didn't make that mistake again. But you have to allow yourself space to make those mistakes and be corrected by your patients, or let your patients roll their eyes at you or let you have it, and then move forward from that. And then the final part of this slide is letting your actions and words during the patient encounter serve as your primary form of being available or being affirming. And so use the physical clinic environment. And so put up a transgender rights flag, or put up pamphlets that both affirm anyone along the gender identity spectrum, to make sure that people know that they're included and it's not just for cisgender individuals. Those are just some examples with that. But if you check out that podcast, it was amazing, and check out Core Internal Medicine because they really do some phenomenal work. And then I think I missed this one. Okay, if you're unclear, just ask. So just ask the patient what their pronouns are and then move on from there. If you fumble through it, it may cause you a little bit of awkwardness at the beginning, but you'll be fine after that. So as far as the sexual risk assessment is concerned, this is from the Centers for Disease Control and Prevention. You guys have all heard this before. The sexual history taking, the 5 Ps. So asking about partners, who your partners are. A lot of times people will say men, women, or both, but a lot of folks are finding problems with that. We need to go beyond that binary when we say men, women, or both. Practices, what do you do? Are you drinking? Are you injecting drugs? A past history of STIs. What protection do you use for STIs, including PEP and PrEP, or treatment as prevention? And then finally, pregnancy plans, if that is applicable in your patient's situation. And so what's the missing P? Like I said earlier, I think we don't talk about pleasure as much. So for me, talking about someone, and when we're talking about sexual history, talk about what pleasure they get out of it, who are they pleasuring, what are the things that they do, the behaviors that they engage in, not just from a risk perspective or a pathological perspective, but what their pleasure is with this. And you'll find that people feel a lot more comfortable acknowledging any of the quote unquote risks that they take. That can also help you as a provider know if you need to do some targeted STI screening, or what kind of vaccination or prevention options you want to make available to them. This is from, I'm trying to think where I got this from, Physician for Reproductive Rights, I believe. And it's a sexual history taking template, and expands a little bit on what the CDC says. So talking about gender identity, sexual orientation, we also expand, so you want to talk about sexual coercion, possible abuse. Sexual activity, we talk about the number of partners, how often you're having sex, what types of behaviors, whether you use toys or not. For men who have sex with men who bottom, whether they use douches for cisgendered women or transgendered men. We could look at anal sex, or anyone along that continuum. Are you using douches or enemas when you have anal sex? Those are the questions you want to get into. It seems very personal, and obviously it is. but you want to start off and slowly get to that and ask some of the questions in a non-judgmental tone. Doing STI history and risk assessment, pregnancy history and risk assessment, contraceptive behaviors, and then finally substance use as well, including alcohol and other things that we see like meth nowadays, which is happening a lot more than with Black MSM than used to in the past. So beyond the sexual history, I just want to talk about facial expressions, attitude, your judgment, and your body language. And if you're making a stank face when someone tells you some of the behaviors that are considered sexual with them, it doesn't matter what you say or how you say it to them. If they sense from your body language or from your facial expressions that you're judging them, that'll be a turnoff to some of your patients that are coming in. So I just want to keep in mind with people that it's beyond what you say verbally. It's beyond what the questions are that you're asking. You want to really pay attention to how you're interacting with the patient at that moment. And fix your face. That's where the title of this came from. Because if your face looks like the person on the right, it's not going to be a good thing. All right, so beyond asking questions, I'm going to give this example. And this was something that happened earlier this year when I was off on unpaid leave taking care of my mother in New York. This is the story of Andre, a 23-year-old Black same gender loving man. Obviously, Andre's not his name, but just for context, he was a student that I had seen before in clinic and had prescribed PrEP to him before. So he texted me out of the blue and said that he had a condomless sexual hookup within the past 24 hours. His last HIV test was 3 months ago. And he didn't know the status of his sexual partner at that time. And he called or he texted me at that time to ask about post-exposure prophylaxis. Now, obviously, I was on unpaid leave at the time and I was in New York, so I couldn't actually see him. But the advice to him, what would be the advice to him? And obviously I thought he qualified for PEP, so I referred him to a local clinic in Atlanta where I knew he could be seen and who I knew would provide PrEP to him. Okay, so when he presented to the nurse practitioner and medical director, the nurse practitioner started it off. And after he told him what happened, he said, well, your risk is low. And the explanation that he gave was because Andre was a top. And so since he was a top, he didn't feel he was a candidate for post-exposure prophylaxis and felt that he just needed PrEP. And so he said, okay, we'll get you some labs and we'll get you set up for PrEP. Andre is a smart young man. And so he said, no, I've read about post-exposure prophylaxis. I had sex without a condom. I don't know this guy's status. I want to get PEP. So the nurse practitioner brought in the medical director. The medical director came in and agreed with the nurse practitioner and said, you know, since you topped, you should be fine. And these are exact quotes from when he was texting me what was happening at the time. And then finally, the nurse practitioner, after the argument kind of continued on, the nurse practitioner said, well, if you had told me that there was a condom involved and it had broke, then I would have readily prescribed the medication. And that last quote was a little bit concerning for me, actually a lot concerning for me. And the reason being is that it wasn't that the nurse practitioner felt that Andre's risk was low. He knew that Andre's risk was high. The problem was that he's making a judgment call because Andre had chosen or had consensual condomless sex. And then he was basically telling on himself and saying, well, if you told me that you had started off with the condom and then it broke, then I would have prescribed you the medication, which was obviously very problematic. So Andre's thoughts at the time, and these again were exact texts from him at that moment. He said, I didn't get a chance to explain all of it because we started arguing. That was him and the nurse practitioner. But I did tell him that I was out of my mind. My phone was stolen the next night or the same night, and that drugs and substances were involved. He went on to say that the guy he had sex with was snorting coke and making me inhale these poppers or whatever that stuff was. And so obviously when you're thinking about drug use, condomless sex encounter with someone met on a social app that you've never had sex before and you don't know their HIV status, and now there's coke and poppers being involved, this is what would we consider traditionally a high-risk environment. But according to this clinic's protocol, he didn't meet the criteria for post-exposure prophylaxis. And what kind of broke my heart about this was that Andre said at the end of the day in a text, he said, I just felt devalued as a person. So he said he got deflated with it all, and he ended up leaving without PEP, but getting the labs and getting a prescription for pre-exposure prophylaxis, even though he had come within 72 hours of the window period that is within every protocol for post-exposure prophylaxis. He left without getting that, and he felt devalued, which really broke my heart. Another situation came up, and this is just me in my personal life, because all my friends know that I'm a sexual health doctor. I do a lot of work with HIV and PrEP and PEP. They always come to me, and I know you guys understand this as providers. Your family members, your friends will call on you for advice all the time. So during a drive from New York to Atlanta, I had a lot of time on my hand, and a good friend of mine, upper 40s in age, he's a gay man, doesn't have a current partner, a steady partner. He called me up out of the blue, kind of similar situation to Andre, where he said, look, David, I need your advice. I have a family medicine doctor that I see, but he knows my whole family, and some of my family members don't know that I have sex with other guys, that I'm attracted to other guys. And he said, I topped this guy yesterday. And again, it was within 24 hours. He said, I didn't use a condom. And these were the phrases that he used when he talked to me on the left. He said, I did something stupid. That was what he started the conversation. David, I want to talk to you because I did something stupid. And then he said, I know I'm being paranoid. And he kept apologizing during the conversation. And he said, I know I'm being a hypochondriac. And what this spoke to me is that there's kind of an internalized sexual stigma with this, both around condom use and just around sexuality in general. And for those of us that have been in the HIV world for a while and doing sexual health and HIV prevention, we understand why this exists, but because before we had PEP, PrEP, and treatment as prevention, all we talked about was condom use. So still within some of our patients that may come into our settings who are a little bit older, they are still worried when they don't use condoms, and they still have that shame and that guilt because it's been ingrained in our brains that if you don't use condoms, you're kind of a shameful person, you're a bad person, you're horrible for having condomless sex because of you knowing the HIV risk over there. So after I counseled him and got him to a place, not the same place I referred Andre to, but to a different place that I know would take care of him well, I told him that I wanted him to change his language a little bit. So I asked him flat out, I said, well, was the sex good with this dude that you had sex with last night? And he said, hell yeah, it was good. And I said, well, okay, so instead of saying I did something stupid, just say I had some good sex. Even though you didn't use condoms, that's in the past now. You can't correct that. So don't beat yourself up and don't call either yourself or whatever you did stupid. I know I'm being paranoid. Change that to saying I know the reality of STIs and HIV out there. The fact of the matter is that people can still enjoy fully fleshed out sexual lives with or without condoms by their choice, and yet and still know the reality of HIV and STIs out there and get tested in a responsible manner. These two are not mutually exclusive. So we can talk and walk and chew gum at the same time. So instead of calling yourself paranoid, just say, I know what's going on with HIV and STIs out there. And since I had condomless sex, I think I need to be tested, or I think I need PEP. And instead of saying, I know I'm being a hypochondriac, don't call yourself a hypochondriac. Just say I'm proactive about my sexual health. I would rather, as a clinician, have someone come into me worried about something, and then me as the provider say, you know what, it's not as bad as you think, or we did all the testing and everything looks fine, or just reassure them, rather than someone do something, blow it off, and say, oh, that's not risky at all, or that's not a problem at all, and then have a bad outcome later. So I tend not to call people hypochondriacs, and I do think it's stigmatizing and often very dismissive of people who are trying to be proactive about their care. And if you're that concerned that they're being a quote unquote hypochondriac and you know it's related to anxiety, particularly medical anxiety, take some time with your patient and try to unpack why that medical anxiety exists. And if you can, or send them to a mental health counselor if you don't feel equipped to it. I think there are a lot of things we can be doing rather than just labeling them as that. And he said, after we spoke, he was like, man, I never thought of this before. And I actually tweeted the story on Twitter not long after that. I think it was in December or earlier this year in January. And the tweet went viral, and there were so many people, not only in the United States, but internationally, that felt the same way as far as like these stigmatizing phrases that people have internalized, and how to kind of acknowledge risk, but still be a little bit more positive and affirming about it without making people feel bad, because that's what turns people off to our sexual care at the end of the day. This slide is expanding on that context a little bit and just talking about language matters. So on the left-hand column, you have a lot of stigmatizing language. And it doesn't matter whether you as the provider or healthcare worker think it's stigmatizing or not. What matters is that it can be received as stigmatizing. And so when you say phrases like HIV infected person or AIDS patient or HIV or HIV carrier, it's a simple change to just say something like a person living with HIV or someone with HIV, or even a lot of people have just say I'm HIV positive, rather than kind of personifying it. It's kind of similar to in medical profession where we say, oh, our diabetic or our asthmatic or our sickler, when we're talking about people with sickle cell disease. It's a simple change, but it means a lot to people. Don't personify the disease. Died of AIDS, instead died of AIDS-related illnesses. Full-blown AIDS is a favorite of mine because I don't know if there's a half-blown AIDS or a quarter-blown AIDS, but that's an archaic term, and just there's no medical definition for that. Became infected. I think, and where I really learned about this was a woman in Florida at an HIV conference who had been living with HIV for like 35 years. And she got it from IV drug use. And she basically said, look, I don't like to think of myself as infected for 35 years. And so realizing that that terminology really tends to put off people, stigmatizes them, traumatizes them, triggers them, whatever word you want to use. But it's a simple change that we can use in our behavior, not only when we're talking with patients, but then when we're doing presentations, when we're writing up medical journals, it's a simple change. Obviously, compliant and adherent is one of those things we talk about as well. And then instead of saying prostitute, which has a negative connotation to it, use phrases like sex work or transactional sex. And again, I'm not trying to be the condom police, the language police, anything like that, but it's just the recognition that especially in this world of biomedical sexual health and biomedical HIV prevention, we as providers, prescribing providers, are the ones that are the gatekeepers to this. And if anything we say or do or our mannerisms turn a patient off, it won't matter how good our science is, how good HIV prevention is, how good PrEP is, how good treatment is, prevention is, or if we come up with a vaccine. If our patients, our communities don't trust us or are turned off by our style or our approach, we're not going to get anywhere in this epidemic. So shifting the focus, I went to a conference not too long ago and I don't know her name. She was a professor at a university, and I apologize because I always use this slide, but I can't give the proper credit. But just know that it's not mine, so I didn't come up with this analogy. She used the Skittle analogy, and what she said was, if you're reaching into a bag of Skittles, use the analogy that say the yellow Skittles were HIV, and you're having sex, and that's reaching into the bag. Depending on what zip code you live in, or what state, or what city, there will be more of those yellow Skittles. And so when you're dipping into that bag, you're doing the same behavior that someone would be doing in another zip code or another state, but your likelihood of grabbing one of those yellow Skittles is greater. So assess someone's safer sex practices when you're doing a sexual history, and describe the geographic risk. So instead of saying, so-and-so patient, you should have used a condom, you're a bad person for not using condom, waving your finger paternalistically and say, you should have been using condoms. Say, you know what, I understand you probably had some good ass sex the other night, and that's great. But you do know you live in this zip code, and there is a lot of HIV and STI, so you got to be really careful. And so what that does when you phrase it that way is it shifts the focus away from blaming the individual and making them feel bad about things, which they already know they put themselves at risk. They don't need you to shame them about it, and just focusing on something more general, like, look, in the pool you're dipping in or in the Skittles bag you're reaching in, it's more likely that there's going to be an STI or HIV there. Discuss sexual networks. Who you're having sex with is just as important as the behaviors that you're engaging in. And then offer help, not judgment. It's not our role as providers to judge people for doing things that, frankly, a lot of us do in our marriages, in our homes, and with our partners at home, and then adopt the do as I say, not as I do mentality. So don't judge people, just focus on offering help because they need it in that time frame. We're coming to the end here, so I'll leave a little time for questions. But these are some tips. Embrace cultural humility. Ask first, avoid lecturing our patients. Spend more time affirming and supporting, no judgment or STI or sex shaming. Go beyond the diagnosis, and then prepare for disease intervention specialists if there's an STI diagnosis. So just a quick slide on this with disease intervention specialists, because I've had some very interesting experiences that patients have relayed back to me. When a positive STI diagnosis is made, Make sure you find out their home dynamics. Do people at home know that they're sexually active, if they're younger, if they're living with HIV, if that is the case, if they have other people that are always in their business, if they have their own phone, so on and so forth, to see what the context is. Let them know that someone will be contacting them from DIS, but explain that it's part of a team approach. Like, this is an extension of what I'm doing for you now, and they're going to take it from here. And these are the questions. They're going to want to know a lot about your business, so just be prepared. Prepare them for it. That little statement in and of itself will do a lot, depending on the tone or the approach of the DIS person, because a lot of times I've heard stories from patients that some of the disease intervention specialists they've interacted with have been rude or very blunt or came off as nonchalant with it. And you have to kind of tell them that, look, this is their job and this is what they're supposed to do. And it's to protect you and to protect the larger communities. And so I always tell them, I know it's a pain in the ass, but just so that they know, and that they'll be calling you by phone or they may be coming to your place, always helps to give them a little bit of a heads up. So as you can see from what I've been talking about, and this picture kind of entails, as providers, we are really looking into what's going on with our patients. And I think when we talk about sexual history taking, the tone with sexual history taking, using certain phraseology or words when we do this, where the literature falls short is that we don't have prospective trials comparing different approaches and then leading to outcomes. So I think in the future, from a public health perspective and from a research perspective, we're going to have to do a lot more work with proving that some of these things actually work and that some of these things actually lead to better engagement in care, maybe less risky behaviors if you want to look at it like that, or adherence with medications, whether it's STI treatment or HIV treatment, so on and so forth. I think we have to look at that research, because for some people, unless it has a p-value or a confidence interval or a prospective trial associated with it, all of these are anecdotal stories. And so we have to kind of take some of the anecdotal stories and move forward a little bit on that. Okay, so in summation, preventing STI starts with conversations about sexual health. The sexual history, believe it or not, actually starts with introductions and greetings. Sexual history taking is about as much as tone as it is about the questions themselves. Please recognize and acknowledge your own bias. And I'm a firm believer that if you don't feel comfortable with sexually diverse or gender diverse people, refer them to someone who is, because if you're not up, or you know because of your personal beliefs or your personal background that you can't do it, don't try to fake your way through it or to just kind of plow through it, because your tone, your body language, your mannerisms will all kind of cause a problem with that. And then training should and could happen early in healthcare professional schooling. So whether it's PA school, nurse practitioner programs, nursing schools, public health schools, or medical schools, we should start this training early on, when they're first or second years, or when they just start, even before they see patients. And I know it seems like people have too much information as it is, or people have too much hardcore science knowledge that they have to learn at the same time. But if we don't integrate this into our curricula, we're really sending out a whole bunch of people out there who are not culturally competent, who won't demonstrate cultural humility, and they won't understand why patients don't engage in care. And this is my favorite character from Black Panther. And I know some of you may be watching this and think, well, we do things right and we do things pretty good. We have pretty good adherence and engagement. And what I always remind people is, just because something works doesn't mean it can't be improved. So even for myself, I think I do a pretty good job. But as patients have told me before, when I misspeak or when I do something wrong, it's kind of like, yeah, I think I do need to improve upon that. Because just because it's good doesn't mean you can't improve upon it. Here's a list of some resources, and I know that Brandon has this slide set and hopefully can get these to you, but these are not HIV specific. These are more about general sexual history taking. And if it's just the general website like cdc.gov or nyc.gov, just look along or search for sexual history taking, because some of these websites have some great and phenomenal training programs, and also just some practical information about how to be a better sexual history taker. And then finally, here's my information. I'm on Instagram, I'm on Twitter. That's my personal email. Don't know if I'll land in another academic setting anytime soon or where I'm gonna be, but these are the best ways to reach me for any questions. Any of the articles I provided, I have PDFs of those as well, or if you just want to comment or throw tomatoes at me through email, you can do that as well, since everything is virtual nowadays. But I thank you guys for your time, and I'll take any questions because we have, I think, about 10 minutes left.
Awesome. Thank you so much, Dr. Malebranche, especially ending with that quote. I definitely appreciate that. It's one of my favorites from the movie as well, too. So moving into that Q&A session, just as a reminder, please send any questions that you have at this time to all panelists, and we'll kind of go through and read those off to Dr. Malebranche as they come in. We do have a few to start off with, though. The first one I'm seeing is, could you go ahead and describe what PEP is and the difference between PEP and PrEP for those in the audience that may not know?
Oh, absolutely. So I'll start with PrEP, which is pre-exposure prophylaxis, which is basically, it's a program, so it involves more than just a medication. But right now, there are only 2 FDA-approved medications. So it involved taking a pill once a day if you're HIV negative that can be up to 100% effective in preventing HIV transmission or preventing you from testing positive for HIV. And so people will get on PrEP if they are with a partner who is living with HIV or HIV positive, or if they just want an extra safety net in addition to condoms and other things that they use. It doesn't prevent against other STIs, but it is highly effective in preventing HIV. And in the future, we should have more modalities to help with that. So we should have injectable pre-exposure prophylaxis, transdermal we're talking about, implants, similar to Norplant with contraception, microbicides or gels that you can apply to the vagina or the anus. So there are all these different things. So that's why I tell people that PrEP is kind of a sexual health program that focuses on HIV prevention. And then when we talk about PEP, that's post-exposure prophylaxis, which pre is that you take it before. So in case something happens, you're already covered. Post is if you're not on any medication to prevent HIV to start with, and you have an exposure, like I said, with Andre or with my friend, and then within 72 hours, what you would do is take a full HIV treatment regimen, which involves 3 medications, and you take them for 4 weeks. And what it does is it gets the HIV medication in your system. So in case you got exposed to someone who's living with HIV with a high viral load and you're HIV negative, the science behind it is that you'll have enough medication in your system that it will block HIV from taking hold in your body. The studies that show its effectiveness are based on needle stick exposures for healthcare workers. Like if you were drawing blood from a patient who was living with HIV and stuck yourself by accident, but they have been translated over or kind of adopted over into non-occupational risk. So whether it be sexual risk or IV drug use, or some kind of exposure from then. So that's the difference. Pre-exposure prophylaxis is you take it every day to prevent before an event happens. Post-exposure is after the event. You take a full HIV treatment regimen for 4 weeks. I hope that explains things okay.
Great, thank you. Moving right into our next question. One of the attendees asked, what suggestions do you have for providers receiving and responding to a patient disclosing a sexual assault that was either recently or sometime in the past?
Yeah, so I think with a sexual assault, it depends on the institution. People have different recommendations for that. You do want to get law enforcement involved and check with the patient, obviously go with them and encourage them to have that conversation, whether it be immediate or later on, just so they can document what happened. And then depending on the institution, obviously there's what they used to call a rape kit or a sexual, I think they don't use the word rape because it's kind of a archaic language, but more of a sexual assault kit. And whether it be an urgent care, primary care clinic, or an emergency room clinic, what they do is based on the patient's history and what happened, they'll take swabs with everything. You have mental health counselors or caseworkers involved, and get the patient lined up from that. And so again, it is going to depend on the acuity of the situation. If it just happened, there's more you're going to be able to do. But if it happened weeks or months ago, or even days ago, and if the patient has washed themselves or cleaned themselves, there's a certain limitation with that. And a lot of times what we will do, depending on the exposure and depending on when the patient comes in, we will prescribe post-exposure prophylaxis if we are worried about they may have been exposed to HIV. And then also, obviously, if the patient feels comfortable, getting the name or the person who actually did the assault would be helpful as well. But getting all those things in line. But I think there's not a national kind of strategy with that. Different institutions go a little bit farther than others and do a little bit better job than others. It just depends. But I think there are some resources on the CDC about that as well. So, and also the New York City Department of Health has some resources on kind of post-sexual assault care for patients that come into our clinics.
Great, thanks. On to our next one. Any advice to communicate with teenage boys, males? How to involve them in care and other programs?
Yeah, it's hard. It's hard with teenage boys. They're a tough nut to crack. What I do in my experience with student health, and also I have colleagues who are in adolescent medicine and pediatrics, is just kind of be conversational. So approaching it, and it's even more important to not approach from a judgment or finger waving perspective. So asking some of the questions, making everything seem normal, making everything normalized, and then engaging them to talk about things, and just starting off with the right questions. Like, most people by your age have already been having sex. Have you been having any sexual behavior, or the oral sex or intercourse? Have you done anything with any partners recently? And then kind of slowly build into it. But I often use some of the questions and some of the things that CDC recommends, New York City Department of Health recommends as well, is starting off by saying, like, look, I ask all these questions to everybody, so don't think I'm picking on you. Also letting teenagers know, whether they be male or female or any of the gender identity spectrum, I'm not going to be telling your parents or your guardians. So what you say between you and I are going to be confidential. And if the parent is in the room, having the parent leave the room so you can have a conversation, no matter how overbearing the parent may be and how difficult that is to ask that question or awkward it may seem, it'll do wonders to help to establish some kind of trust, so that adolescent and young adult patients actually feel more comfortable revealing more honest and truthful responses to their sexual behavior, because they're not going to always admit what's going on with a parent or a guardian or an elder figure sitting right in front of them. Those are some of the things that I would start off with. But some of these sexual history templates and suggestions from some of the websites I provided have some caveats with that as well. So if you're interested in more of that, those are some of the websites to get some more information. But those are some initial things I would recommend.
Awesome, thank you. So we've gotten about 2 or 3 questions right in a row, a little bit more pertain to the DIS role and kind of how they interact with providers and other folks in community-based organizations and within the sexual health field. So I'm going to kind of bleed them together, as I think that they kind of correlate a little bit. So effective approaches for providers to elicit partners in order to test and treat them, so that way the DIS aren't the first ones asking about partners. And then also kind of that going into the I know it's a pain in the butt suggestion that you made earlier, in terms of like that warm handoff. The individual said that this would entail saying that DIS workers are compassionate, caring, and it's all confidential. This type of work helps to keep you and the community safe. It's good to hold up the public health workers so that there's not a stigma against their work. Snaps that. And then also, how would you suggest an disease intervention specialist do when a provider refuses to talk to them about a patient that's newly diagnosed with syphilis, and specifically in this question, but I think that may go in general terms to all other STIs as well.
And you said when a provider refuses to talk to a DIS person?
Yes, that's how the question was phrased in our chat box.
Okay. Yeah, I haven't heard that, but I imagine it must happen. But first, let me say, let me apologize for the phrasing, because when I said I know it's a pain in the butt, I didn't mean I know that DIS are a pain in the butt. I didn't mean to say that. I meant the process itself of having to go through all this stuff and answer these questions all over again, or give a lot of details about your sexual history. So I think you're right. And I think one of those comments was more so a comment than a question, but I do think as providers to couch it in a more affirming way and say, look, these people are wonderful. They're public health warriors. and they're trying to make sure that you're healthy and the rest of our communities are healthy. So they do this because they have to. It's going to be completely confidential. They won't share your information with anything. Those approaches are really good, because I do think that some providers may kind of bias that and skew them to think it's going to be some kind of adversarial thing coming in. And that always pumps up the patients to be thinking it's going to be a fight when they get in there. Regarding your question with a provider that doesn't answer the question, providers are required by state law to report these things. So I know they're not required to report about who the partners are, but they are required to report these things. But I understand it may be difficult if the provider doesn't want to do that. To be honest, that would be a tough one. I don't know if I have a quick answer or a good answer within a minute or two that would actually foster that, because some providers, I mean, obviously I'm a provider myself, but some of us can be real jerks and real kind of protective of these things and not want to work alongside with that. But they should be required. And I just saw someone commented that in Wisconsin they're required. And I think it's going to vary by state, but they're supposed to. But I would say check with the state guidelines, because you can bring it up. And if it's a provider you have a problem to, you can go to the clinic manager or the hospital administrator or other upper level administrators and bring that, because what you're doing is a public health service. So whatever that individual provider, for whatever reason that they're not disclosing that stuff, you should be able to go to the state and be able to get that information, because you're working for the public health good. So if they're being adversarial like that, that's not it's not only against the law, but it's unethical on a lot of levels as well. But that is challenging. I haven't experienced that before, and I haven't seen that. And public health is exempt from, I see that comment too here. Remind, public health is exempt from HIPAA when doing public health work. You're absolutely right. And so, you know, a lot of those HIPAA violations go out the door. And in some states, depending, particularly with HIV disclosure, it says some states are more rigid and will say, well, a provider is not supposed to disclose someone's HIV status to potential partners under any circumstances. Others say things like, well, you can if it is perceived to be a threat. Like if your patient comes in and says, well, I have my wife or my partner and we're having sex without a condom. They're negative, but I'm positive. I'm not on meds, and I don't feel comfortable telling them about my HIV status. As a provider, you have the right, you are legally backed to be able to disclose that status to that partner. And so, but again, with the United States of America, everything is a little bit different depending on the state. So you have to check with your state laws. So I appreciate the folks that from Indiana and Wisconsin that were saying that, because I think it really depends on the states to know what the legal rights are of the patient, what the legal rights are of the provider, and what the legal requirements are of not only the DIS people that are trying to do their job, but also of the providers, whether they can disclose some of that sensitive information. That's a great point. That's a great point. Thank you for bringing that up.
Awesome. And then Dr. Malebranche, if you don't mind, just one kind of like last little clarifying takeaway message for the audience. Can you talk about like one maybe key takeaway or action item that you would say based on the information that you provided today and your experience in this field in general, that nurses, physicians, DIS workers, and all other folks working in sexual health and reproductive health can really do to start making a positive change in their healthcare setting?
Yeah, and that's a good way to end off. I think what I would say is there was a slide that I presented earlier that talked about, and that was from the Core Internal Medicine podcast about transgender health. It was more about not just doing what happens in the clinical space or in the one-on-one interaction, whether it's provider and patient, staff and patient, DIS person and patient, or community member, but it's about the larger social and structural things. So the environments themselves. So create a more welcoming environment, create more welcoming policies and guidelines and protocols for the DIS workers, for the clinical staff workers, for everyone else that is involved on this continuum, because it can be one-on-one, but if you don't mandate it and put it as a protocol, you can see with the example I gave with Andre, they said it was their protocol to not give PrEP to someone who topped but had condomless sex in a high-risk situation. I don't know any protocol, national, international, local, that would say that, but it stresses the importance that we have the power within these settings, but not just on a one-on-one level, but actually to create the policy and the structural environments that make it more welcoming so that these things are actually required. And then I think that works. So if it's one take home I would give it, I would say not just to do the one-on-one stuff for your own personal work with patients and community members, but to also be part of the creation or the advancement of the structural and environmental change as well. That's what I would say.
Awesome. Thank you so much. Thank you again to Dr. Malebranche for your time today, for being able to deliver such great messages for all of us to go out and start to implement in our healthcare settings. Also, please note that this presentation will be available for future viewing through HCET's events page on our website, which is www.hcet.org. Please be on the lookout for an event evaluation that should be coming out shortly following this webinar. Your feedback is highly appreciated. And then again, thank you, Dr. Malebranche, and I hope everyone has a wonderful day.
Thanks, everyone.